Hello, my name is Tapan Kadia. I'm currently Associate Professor in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. Today I'm going to be talking about some of the data that was presented at the current ASH 2020 meeting, which is being held virtually because of the COVID-19 pandemic. And one of the topics that has come time and again in these meetings is the concept of low-intensity therapy in older patients or unfit patients with newly diagnosed acute myeloid leukemia. For years, we've used low-intensity therapy in these patients because of the risk of toxicity and the high rates of early mortality that is often seen in older patients with intensive chemotherapy, which may not be suitable for all these patients. And so those low-intensity therapies amounted to essentially a single-agent 5-azacitidine or single-agent decitabine, both of which hypomethylating agents, with the response rates in the range of 30% and complete remission rates in the range of 18 to 20%, with a median overall survival of 7.7 to 10.4 months. And so, although the toxicity was certainly less and the treatment was better tolerated, we lost a bit of the efficacy that we often see with intensive chemotherapy. And so, just in the last year or two, since the discovery of venetoclax, the BCL2 inhibitor, and its activity in AML in combination with low-intensity therapy, such as hypomethylating agents or low-dose cytarabine, we've seen those response rates increase dramatically, with an overall response rates in the range of 65% and median overall survival, at least as evidenced in the VIALE-A randomized trial, of 14.8 months with 5-azacitidine combined with venetoclax compared to 9.6 months with 5-azacitidine alone. And so based on that, there's been a revolution in the treatment of older and unfit patients with newly diagnosed AML, where we are now matching efficacy with good tolerability. And so the tolerability remains. There is some myelosuppression, but overall well tolerated with low early mortality. And so what we decided to do in one of the abstracts that we presented was to take it a step further and to look at new backbones of lower intensity therapy that could also benefit from the addition of venetoclax. And so a couple of years ago, we published a clinical trial that we had been running for years with a new backbone of cladribine, which is a nucleoside analog in combination with low-dose cytarabine, alternating with a hypomethylating agent, in this case, decitabine. In 118 patients, we saw a response rate or overall response rate at CR plus CRI of about 65%, with a median survival over 14 months. And this is, again, without the addition of venetoclax in newly diagnosed patients age 60 or older with acute myeloid leukemia. We published that again with long follow-up, and the effect was pretty consistent across most subgroups. And so our hypothesis was that if venetoclax can potentially improve the response rates as we see with hypomethylating agents, that perhaps we can add venetoclax to cladribine and low-dose cytarabine and try to augment those response rates. And indeed, that's what we did in our current phase 2 trial. We reported on 55 patients that were treated in the current trial with a median age of 68 years. 40% of those patients were over the age of 70, and 44% had adverse pretreatment genetic characteristics, both cytogenetics and molecular, by the ELN 2017 classification. So it's the sort of the classic group of patients that we typically see in this newly diagnosed older and unfit population. And what we found is that among those patients, the complete remission rate with full count recovery was 78%. And the composite complete remission rate, which includes CR and CRI, was 93%. Notably, 84% of the patients who achieved a composite CR had a MRD negative complete remission by flow cytometry, which is an extremely high rate of negative minimal residual disease. Among those patients who had a complete remission with count recovery, that MRD negative rate was 93%. And as we had thought, the 4 and 8 week mortality remained low at 2 and 4% respectively. And overall, well-tolerated regimen in this older patient population. With a follow-up of 14.2 months, the median overall survival and the median relapse-free survival were not reached. And so this was a favorable outcome in this older population. Again, a single-arm study and a short follow-up, but certainly promising results with deep remissions. And about 30% of the patients were actually able to go on to allogeneic stem cell transplant in relatively good shape. So this is sort of potential evolution in low-intensity therapy, which could be potentially more efficacious for this difficult population of patients. I think ongoing studies such as this one, as well as maturing data from this study and new backbones are going to be studied and potentially also looked at in a randomized setting. So I think that there are certainly new opportunities in the treatment of older unfit patients with low intensity therapy in newly diagnosed AML.